Good evening, everybody. Good evening, doctors. Thank you for making it to the meeting today. Um, so as we know, we are looking at the topic USMLE Success and Residency Insight, and I requested for a speaker from AMSA National, and they gave us Dr. Bolu Waduro, and the little we know about him is that he attended the American University of Barbados School of Medicine, and he recently marched into internal medicine. Um, I learned that he did very excellently on his step, and he's also the founder of abmedprep.com and a co-founder of a Baltimore Humanitarian volunteer group that care for over 50 homeless individuals per month. So it's really helpful and impactful as well. So it's a delight and a privilege to have him. No, he's not. But AMSA National gave us his contact because we requested from AMSA National, and yeah, that was it. So I'm going to hand over to Dr. Bolu Waduro to continue this section. So I'll ask him some questions, and also if you have any question, please drop it in the drop box below. If you have any question for him as the seminar is going on, please drop it in the comment box below. Let me share my screen now. Um, Hi, Dr. Bolu Waduro. Can you hear me?
Hi, yeah, I can. Hello, everyone.
Hello. So, guys, this should be an interactive session. In as much as we have some questions for him, if you have any question at all, please drop it in the comment box so that he could answer as we continue with the section. Thank you. So, yeah, Dr. Bolu Waduro, continue.
Yeah, hi. Can you guys hear me?
Yep.
Okay.
So I'll be
Let
muting
me.
my mic now. Um,
Okay.
I'll be, yeah, I'll be muting my mic now so that you can continue. So
Okay.
I'll share your PowerPoint as well.
All right, that sounds good.
Oh,
Oh, I wouldn't be able to share my screen.
yes, I'll have to share my.
I think actually I can.
Okay, check.
Let's see.
Oh, nice. Yep, that's cool.
Okay, so just give me a second. I'll pull up the PowerPoint, and then in the meanwhile, let me introduce myself to everyone. Here we are. My video should be on now. There we go. Yeah, so my name is Bolu, Bolu Adeyemi. Um, I went to school went to two med schools actually. First one was IAU in St. Lucia. That's the International American University College of Medicine. Then from IAU, I had to transfer actually. So I took step one with my old school. Then I moved to my new school because there were all sorts of issues. So I finished my medical degree with AUB, that's in Barbados. So in the process, there's a lot of things that, should I say, it doesn't change much, which school you go to. I saw one of the questions. No, I didn't go to IUHS, but the stuff we'll be talking about today is it's kind of consistent across most Caribbean schools. So today's session will focus more on step one, step two, and then the residency application pathway. But if I can kind of get a sense of like who's here, who I'm speaking to, are you guys like all basic science? Are you guys all clinical science, or is it a mixture of both?
Okay,
I
so
can't.
I'm Lot's Favor. I'm I'm studying for step. Because
Okay. How,
I'm in my second year basically.
okay. Is everyone else here in the second year? That way, I would just kind of touch on step two stuff and focus most on step one stuff, so I don't kind of like waste you guys' time. So is everyone here preclinical? What's favor? You can tell me. Mix of both. Okay, okay, that works. So give me a second. Let me put this Google Meets on another screen so I can still see the chat. There we go. We have M3. Okay, fair enough. So we'll talk about both. Starting from step one. So the PowerPoint I have today's session I was thinking would be more interactive. So I made this slide kind of a while ago, but 90 something percent of it will be current. And if there's anything that's different, I'll let you know. And then yeah, if anyone has any questions, I'd be more than happy to answer. So just unmute if you have to, and then let's chat. So the outline will be step one, content format. Step two, same thing. How the exams are scored, that we'll just touch on because I'm sure a bunch of you already know how that is. But knowing how it's scored is important because it influences how you prep. So to give you reference of like why I'm even like why I'm the one talking about any of this stuff. On step one, I scored 254. So that's at that time that was in the 90th percentile. So you do the whole biostats, you have the graph. That means I scored in the top 10% of people taking step one, and then on step two, I scored 260. So that's top 15%, give or take, maybe top 16% on step two. And then since that time, actually before I took the exams, I have been tutoring. So I've tutored for basic sciences, I've tutored for step one, step two, and a bunch of stuff in between and after that, like I helped all my friends write the personal statements for residency, do the interviews, interview prep. So I've had a bunch of exposure to that stuff, and even people that are my friends who needed personal statement edits, letters of recommendation. It's more about doing research and knowing, okay, this is exactly what you're looking for and trying to portray in each thing that you do. So that's me. That's why I'm here. And then, so yeah, we'll talk about taking the exams, passing, failing. We are all of us in this meeting were IMGs, right? International medical graduates, or we will be IMGs. So failing is not something you want to, how should I say? We'll talk about like how it influences applications when we get there, but you really, really want to do everything in your power to pass the first time and pass well, because us being IMGs, the deck is stacked against us, so you have to, truthfully speaking, you have to do a lot more. You have to make up a lot of ground to have a good chance at matching. But none of the things you have to do is secrets. That's why we're here. We're going to talk about them. And it's kind of like if you keep your head down, you're realistic with what you have to achieve, then yeah, everyone here can end up in the residency spot where you want. So me, I want to do cardiology in the future, which means I have to start with internal medicine. So that's what I applied to. So the program I've just matched into where I'll be starting, it's a program with 13 spots, and the number of people who apply to that program is somewhere around 6,000 every year. So 13 spots, 6,000 applicants. You're competing with a lot of really qualified people. You have to be qualified too for that to be that'll be the baseline of even starting your competition. And then so we'll talk about budgets, we'll talk about what comes after, which is like the residency application process, and then we'll talk about NRMP data and like what it means to you. Excuse me. So this is kind of an overview. This pathway is let me see. Yeah, this about right. So most people will take between 3 and 12 months to do step 1 and step 2 prep. And by most people, I mean us IMGs. It's a little bit different if you're coming from the US system. They often give you just 8 weeks to prepare. But their basic science curriculums are also about eight months longer than ours. So Yeah, between 3 and 12 months. If it depends on where you're at with your baseline, which we'll talk about. If your baseline is like really high, you know a lot, you have a lot of mastery of what you need to know. You're going to not need that much time. But if your mastery is low, which is frequently the case with us IMGs, schools are they don't always prep us that well. So going into your step one prep, you have to know that okay, I'm committing a certain amount of time to get it done. So I myself, I took 7 months to do my step one prep, and just to give you examples of my friends, one took 8 months, one took 9 months, somebody took a year. So you you kind of you know figure it out for yourself. Things are also changing a little bit now, where the schools are, should I say, caring more about how you do on step one because it influences your future and by extension them. So you have fifth semester programs coming up now. I'm not sure how it's structured at IUHS, but yeah, you have to. It doesn't matter if it's 2 months, 3 months, 12 months. All that matters at the end is that for step one, is that you pass. Now, for step two, you have to have a good score. And then we'll talk about why. And then you have US clinical experience, which for all of us here is kind of a given because you're all in the Caribbean system. Unless you rotate outside the US, if you rotate outside the US, chances are that you want to get some US clinical experience before you apply. And then you have residency application, which opens December 28th. So the way the season goes is from June, you can start doing your application. So June, July, August, September. At the end of September, programs will have access to start reviewing your applications. And you really, really want to have your application done by that time. There's some programs that will have deadlines going up to October, November, December. I've even seen January. And so, those ones will review applications more in an ongoing way. But the earlier you can be, the better for you because interviews are often given out not exactly first come, first served, but if they've given out enough interviews to fill their slots according to their own calculation, doesn't really matter how good your application is if they get it in February. So you want to start thinking about being ready by September. And then interview season is December, well, not exactly December, November, December for the most part, January, February, and then they'll start offering interviews. You go on your interviews. Everything's virtual now. Thank goodness. Before you had to actually travel to all the programs. When you do your interviews, then you submit your rank order list in February, sorry, and then middle of March you learn if you matched or not, and then where you're going to go. So for step one, um, before we even go into any of these bullet points here, the biggest thing to mention is that if you're in the basic sciences right now, that's the that's the foundation you're going to have for your step one prep. So, if you're more in the later basic sciences, let's say like semester four, or even if you're in semester five already, then kind of you have to work with where you're at now. But if you're in the earlier stages, like semester one, semester two, semester three, you have a lot of how should I say, opportunity now to set a strong foundation for the basic sciences. And so that's what step one is going to test, right? It's 8 hours. Out of that 8 hours, you have 7 blocks. Each one is 1 hour long, and then you have 45 minutes of break time. You can split however you want. But you have to also be careful with that because there's security procedures that they don't really tell you about till you get there. Going in might be 2 minutes security, coming out might be 2 minutes security. You might spend 5 minutes on security procedures. So that takes out of your break time every time you have to go. So that's something to think about. Each question is 40 questions, MCQ only. Choose a single best answer. Something that's salient about step one is that a lot of the questions are experimental, and that's you're not going to have any way of knowing because if you have 7 blocks of 40 questions each, out of those 280 questions, some of them will not count towards your grade, but you will have no way of knowing which ones that is. So sometimes they think that a piece of advice that's given when you're taking the exam, if you have a particularly challenging question, answer it as best you can and maybe comfort yourself that okay, it might be an experimental question. But that's the content and format. That's not so much what's important. What's important is how you well, of course, it's important, but the more important thing is how you prepare for the exam. So, this is just some more stuff from the USMLE website showing you the breakdown of what is there on the exam. Obviously, everyone knows that path, farm, and physio, the three P's, are the three highest yield things on the exam. But I actually don't like showing this table just the way it is, because you'll see that histology and cell bio is all the way down here with a range of 8 to 13% of information on the exam. And in my experience, I found that that often causes students uh, to not care much about their histology performance. But then there's a reason why you do all the courses in the order you do them, where you start with knowing what's normal first, that's anatomy, histo, cell bio, physio, and then you move on to what can go wrong in the body. That's your micro and your pathology and pathophys. So if you're not good with what's normal, if you've completed your histology course and you cannot stand on the spot and describe, okay, this is the histology of the thyroid gland, for instance, when you're shown a picture of an abnormal thyroid gland, you wouldn't even know where to start. So I always caution to be careful of interpreting this table the way it is, because everything you learn in histo will come back when you have pathology to do, and that's um, what Favor mentioned. I have a coaching company I founded, and so at any given time, I have about 10 students I'm guiding through step one. And one of the things I have to work on with every student, in my experience, is teaching them how to read histology slides. And so that's something you don't want to look at any class of step one material and be like, okay, this is not high yield. I'm not going to pay attention to that. So don't don't put too much stock in what this table says. Just the goal. One of the questions what Favor sent me was that what advice would you give a first year student or someone studying for step one? And the best advice in my opinion, is that you're you're in med school, so obviously you want to be a physician, and so everything that you're doing, it's not for the next quiz, it's not for the next exam, it's not even for step one, it's not even for like when you take boards. It's because at some point, there'll be somebody in front of you, and medicine is different from a lot of professions where the amount of knowledge you have directly translates into how good of a physician you are. It's not the only thing that matters, right? Because you still have to have empathy, you still have to care about your patients, you still have to do what's right, you still have to advocate for your patients, all that stuff. But if you don't have the medical knowledge to begin with, even if you're the kindest person in the world, you're not much, use as a physician. If the knowledge is not there. So yeah, absolutely keep that in mind from day one. That's what you're working towards. It's not anything, not even really anything before that. And in my experience, the students who do the best on step one and step two, and with the boards going on, and eventually, of course, residency and everything, is the ones who have that mindset. Having the mindset of this is what the professor gave us, what's going to be on the next quiz, can get someone through school. But the problem is that you're competing with people. Your competition is not the people in your class, it's not even people in the Caribbean. Your competition is the best minds that the US has to offer as a country, right? In terms of the people who apply to med school to begin with, and then the people who are selected from there to go into med school, and they have that understanding from day one that I'm grinding, 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 I have to be the best. If that's your competition and you're kind of like wishy-washy, then you have a problem even before you get to step one prep. So that's the best advice I can give in the basic sciences. So looking at sample step one question, I'm not going to spend too much time here. It's just you've seen this already. You're in med school, but it's often multi-step, and that tests how well you can synthesize information, right? Because it's not going to ask you, okay, what's the structure, or what does that do? It wants to see, ever the diagnosis. If they want to be kind, they'll stop at what's the diagnosis. But they often don't want to be kind, so they'll ask you what's the pathophys of the condition. So you have to first diagnose, then you have to see the pathophys. If they want to be even more unkind, which also happens frequently, they ask you what's the side effect of the drug you're going to have to use to treat this medication. So to treat this condition. So you need to be able to diagnose, you need to know what's going on, the pathophys, you need to know the drug, and then you need to know what's the side effect, which is how you have to think as a physician, right? Nobody's going to show you a picture and say, "Oh, do you know that that's a granuloma right there?" Like, no one's going to do that. So, like in this question now, always you start right by reading the last line. Which of the following is most likely to be found on the cells indicated by the arrowhead? So they're pointing out a cell in histo, and this it goes back to what I'm saying about a lot of step one questions will show you histo. So you have to know what you're looking at here. You have to know what the structure is. Then you have to know what cell they're pointing at there. And so they say it's a middle-aged male. He came from Sri Lanka 2 years ago because of 1 month history of fever, cough, weight loss. So you already start doing your differential, right? You start thinking it's an immigrant. You kind of have to be a bit step one. I don't know what's a good word to use other than actually I don't know a good word to use, so I'm just not going to use any word. You have to assume that there's no physicians in any countries people are immigrating from, which is daft, but that's how the step one exam is, right? So if someone's an immigrant, there's no doctors in their country, they got no vaccines, if they had an infection, it didn't get treated. If it's a pregnant woman, she had no prenatal. It's very stupid, but that's just how step one is. So he's an immigrant from Sri Lanka with weight loss. So you start thinking TB. After TB, you start thinking, okay, maybe he has cancer, right? And then chest X-ray shows infiltrates in the upper lung fields with cavernous lesions. So now that confirms TB. So they did biopsy and they took a lesion from the thing, and so they're asking you uh, what. So you have to first in this question be able to diagnose that it's TB. Then you have to know that okay, in the histology of TB, what do you expect to see? You expect to see non-caseating granulomas, but that's for like once you'll do micro and path and onwards. You know, if you haven't done it yet, don't stress about it. And then you have to know, okay, this is granuloma. What type of cells do you find in granulomas? Giant cells, which come from macrophages. Those have CD14 as their marker. So that's how step one questions are, and you have to always be prepared for that. Be prepared to synthesize information, which means you have to understand information. Yeah, essentially that's it. So on step two, I've highlighted everything on this slide. This is for when you get to, obviously you would have done your core rotations and you have step two either at the end of your course before you do electives, or some people take them at the end of electives. Some people graduate before they take them. Whenever you take it, it's the same medicine, surgery, pediatrics, obstetrics and gyne, and surgery. That's what's going to be on the exam. And on like step one is 9 hours, right? Step one is 8 hours. Step two is 9 hours. Step two CK has a clinical contents, more clinical science, and so what that means is that you, funnily enough, something like 30 to maybe 40%. I have no scientific numbers. This is just in my estimation, but there's a very high proportion of step two questions that is straight up step one content. So because of that, I always tell people what I'm coaching, either for step one or step two, that your step one, the height of knowledge that you attain with step one determines your baseline for step two. And you could see that in the past when step one had those 3-digit scores where, somebody scored 230 on step two. A lot of the times you could add between 5 and 20 points. How long did it take to go from, oh my goodness, I missed this question, I'm so sorry. How long did it take to go from block 8 to clinical? I'll answer that as soon as I'm done with this step two slide. So yeah, your step one's foundation needs to be solid, and this is setting a big trap for everyone, both US students and IMGs like us. And here's the trap, right? If step one is pass fail, a lot of people will have their foundational years, basic sciences, and even their step one prep with passing as the goal. But the goal on step one, if you just pass, or if your score is very close to, block 8 is basically MD5. Oh, I see. Okay, so that will help when I'm answering. So yeah, let's finish this slide and then I'll answer that question. So yeah, the passing grade on step one, now they're not going to tell you exactly what it is, but in the days when step one had a 3-digit score, passing was 194. Now it's 196. It won't show you the score, but if you score above that threshold, you're going to pass. Now, if you just scrape and struggle and pass, which is what is happening to a lot of people right now, you set that as the baseline, as a foundation for you preparing, starting to study for step two. So back then, when there were three-digit scores, let's say you scored 200 on step one, which is around what someone who just manages to pass right now would score. You're setting yourself up for somewhere in the vicinity of 220, if you're really lucky, like 230 on step two. Unless, of course, you take some more time, some more months, and make up for it. But a lot of people don't do that. So my point is, when you study for step one, please keep in mind that just passing is not going to be good enough on step two. Is also not going to be good enough in clinical rotations. So step two average score is 245, which means 246. Half of people will score below that, half of people will score above that. Again, us being IMGs, you kind of have to outcompete if you want to be considered for the same spot as a US candidate. It's not exactly fair, but in a different way, it's fair, but it's also not fair. So that's just the way the system is. So my advice to IMG candidates is, myself, always aim for at least 240 and up on step two. And ideally, you really want to be above 250, but 240 and up is still a solid range in which to be. So, yeah, think about that when you're doing your step one prep. If you've already passed that stage, seriously consider, taking the extra time to have the score you want and do what it takes to succeed on step two. And so, just like step one, it's multiple questions, only 38 to 40 questions per block. The only reason you'll see one or two blocks with 38 questions is that they give you these abstracts, which are like 3 pages of PDFs of like what farm reps come and show you when you're in rotations. Farm companies will always be sending people and they'll come tell you about these drugs. So you're going to have to read one of those abstracts, and they're long, so they give you extra time per question to do that. Just like step one, it's single best answer. There'll be experimental questions, but unlike step one, there will be a three-digit score. And again, now that step one is gone, programs are looking for how to select candidates, not select, screen candidates. So yeah, when there were step one scores, if you're applying, you be on the website for a program, and it says, oh, if you scored less than 210, don't even apply. It's not most programs, but there's a good number of programs. I researched maybe 200 programs before I applied. I'll say maybe something like a third of them had that like 210, 220 cutoff. So you can even imagine if someone is barely managing to pass step one right now, let's put you somewhere in the 200 range. The fact that you've escaped that screen, you're still going to answer for it on step two and during clinical rotations. And those things count because clinical rotations, the letters of recommendation you get from your physicians play a big part in you matching into residency. So programs are looking for, okay, what's the easiest screen? What's step one? They're just out of the 6,000 people who applied to a program, some programs 7,000. They'll just like take out a huge chunk of those people just by screening with step one, screen with step two. Okay, you failed. Even if you scored 270 on your second attempt, right? Again, it's not most programs. Like people still go ahead and match with failures, but the chances drop precipitously. You really want to be careful about it. So, okay, you had an attempt, they'll just screen you out for that. Eyes will not even eyes will not even see your application. It's the computer that will do all the screening, and whatever is left is what people will look through. So, you can really screw yourself if you give yourself a chance to be screened out by a computer. And so, yeah, that's what you have to worry about in step two. So this is what I was saying: medicine, surgery, peds, OB/GYN, psych. The main difference with step two compared to step one is that it cares more about management. So if you're taking step two, they kind of assume that you can make the diagnosis. What they'll now ask you is that, do you know the next best step in diagnosis? On step one, they might ask you, okay, somebody has this lesion in this gland. What test do you do next? You might do the hormones, you might do imaging, you might do a biopsy. There's any number of tests you can run, and that's what step one will ask you about. But on step two, it wants to see, do you know which one you do first? When that's the outcome, which one do you do second? When that's the other outcome, which one do you do third? When you've confirmed your diagnosis, how do you start treating? If the patient is in this condition, do you treat with this? Do you treat with the other one? So when you study for step two, whatever resources you're going to be using, pay a lot of attention uh, to management, where there's diagnostics and where there's treatment plans. Because you might have a question, let's say on AFib, right? They'll ask you, okay, they'll give you a case of AFib, and in the options, they'll give you, you know, shocks the person, they'll give you synchronized cardioversion, give you unsynchronized, they'll give you propanolol, they'll give you, let's say, nifedipine, all these things, on not nifedipine, diltiazem, for instance, all four of those things, or three of them anyway, will treat AFib. You have to know which one do you use when and why. That's what step two cares about. So it's people perceive it as being easier than step one because they'll give you the information and they really just want to see if you know it. So yeah, actually, the truth is, I personally struggle with that, and you can see that in the very slight drop of my performance from 90th percentile to 85th percentile on step two because I'm better at understanding things. I can memorize them if I have to, but I don't like doing it. But what you like has absolutely no influence on your step one prep or what your schedule is or if you're breaking up. Give me a sec. Let me give it just like 30 seconds because sometimes my Wi-Fi is crappy. Can you text again? Tell me how the sound is. Okay, thank you. So I think it's back. So anyway, that's step two, and so this is on scoring, right? On the left there's step one, on the right there's step two, and so these are not the actual score reports because I was lazy when I made the slides, but the point to pass across is the same. On these are the self-assessments, the NBME self-assessment you do to see if you're ready for the test. So like looking at step one, you see a low pass range of 61 to 70%. Being in that range, there'll be something like 90. I'm not sure what the numbers are exactly, but 90, maybe 95% chance of passing the test. This is a range you don't want to be in. And you also don't want to be on this side of things because, I mean, look at 50% probability of passing is 24%. So you want to be solidly on this side of things where you're seeing like 99% probability of passing because let's say if you take 95%, there's a 1 in 20 chance of um, kind of failing, and that's kind of unacceptably high. And then on step two, so yeah, when you do step one prep, just always target to have mastery, which is above this band. That's 61 to 70%. So you kind of want to be like just anywhere above 70%. Obviously, the higher your performance, the better you're doing. And then on step two, yeah, you can see it right here. This scores fluctuates year to year. Average score is sometimes 245, sometimes 246. So sorry. So these are for both of these are for students of mine, and so this person had their assessment last year September. So I don't know what the average is going to be this year, but yeah, it fluctuates between 245, 246, and then so this is the passing grade is 214, right? So you can see this person is at a 204, which is kind of slightly below the passing grade, but you don't even want to be anywhere around the side. You want to be like from here and more to the left just to maximize your chances of matching. And I'll talk about the exact numbers and the exact probabilities so that it's not I'm not trying to scare you or anything. You have to know these probabilities because if you do, then you can increase your own competitiveness in the process. Like talking about step one, making sure you have a good foundation before you head on to clinical rotations. When I was in my internal medicine rotation, out of the 12 weeks, you do 4 weeks with 4 weeks with one doctor, 4 weeks with another doctor, and so on. In my second 4 weeks, the attending physician I had, we had a group of like 5 or 6 students, something like that. Each person got their own patients, and but this attending would let only me to have his ICU patients, and it's not an ideal scenario. It's like it kind of looks like favoritism, and technically it is. But I didn't know this physician from anywhere before. It's like me and all the other students were brand new there. But then he has a few days to look at us and decide for himself what he thinks each person is capable of. And he was like, okay, only you're going to have the ICU patients. Now you can imagine that I'm not going to put that in my personal statement or letter of recommendation. It doesn't really make anyone look good. But because I'm in that situation where he can see that, okay, I'm capable, he can write me a very strong letter of recommendation. Or if he doesn't write it, which oftentimes happens, he'll ask you to write it, or she'll ask you to write it, then you write it, and they'll sign it. But if you're a weak student and you write a strong LOR, sometimes they'll still sign it anyway, because honestly, doctors are stressed and burnout. Nobody really gives a damn about anything. But you don't want to take that chance. You want to show up prepared. And it's very hard to be prepared for clinicals if your basic science foundation is poor. So how long it took me to go from block 8 to clinical? So I'll tell you the time periods that I had, and then you see that I had a lot of delays in between. That's actually the period where I switched from one med school to the other. So I finished my MD4, and then I took 7 months to study for step one. And I took step one. I was supposed to start clinicals, but my school at that time had issues where um, there's lots of issues. Clinical rotations were paused essentially indefinitely, and people would wait 1 month, 2 months, 3 months. You didn't know when or if ever that you would get scheduled. So I transferred to AUB in Barbados, which has its own issues. But that transfer set me back because since I did step one, but I didn't do my introduction to clinical medicine course, the new school didn't recognize my semester five as being valid, which is, I guess, what you guys have as block eight. So new school made me do semester five again, which is funny because I was taking USMLE classes after I had taken USMLE. But that was not the objective. The objective was because to have those introduction to clinical medicine classes, which I can't say were useful, but they made me take them, so I took them. So that set me back 5 months, and then, well, 4 months. But then just before I was about to leave Barbados and travel to the US to start my rotations, the pandemic hit, and the airport shut down like I don't know, a week before my flights, or a couple of weeks, something like that. And I physically couldn't leave the island, so I was stuck from um, April, May, June, July, August, September, something like 5 months I spent on that island paying rent, doing nothing. Of course I tried to study and prepare for clinicals, but that's a very demoralizing situation to be in. So that was another 5 month gap. But then after that, I did travel to the US. I was able to start my rotation. So um, in most cases, you don't have to transfer schools unless, I don't know, your school is also having serious problems like my old school was. But for the vast majority of students, that's not going to be the case, right? So once you finish your final basic science semester, just budget for anywhere from 3 to 6 to maybe 9 months for step one prep. Uh, Once you've taken your step one, you can, in most cases, you just go ahead and start your clinicals. So yeah, my situation is not unique. What's the percentage of successful students? That's um when you say what's the percentage of successful students, do you mind just unmuting so I can, because I have a couple of I need to clarify the question. Do you mean like of people who take step one, or people who like from a med school get to the point of passing step one? Like how would you define success in this situation? Okay. Oh, at my school I can't tell you about because I spent 5 months there, 4 months there, technically anyway, before I left. But I can't tell you about my old school. So, um, there were maybe 25 or 30 of us that started the basic sciences together. Out of that, the number that went on to take step one is somewhere around 6 or 7. And those that passed is maybe, I don't know, 5 or 6. Maybe other people have taken them by now, but you kind of lose track of people. So I don't know. Is my school AUM? No, my school's AUB, American University of Barbados. Their own success rate I can't speak about because, like I said, I was only on the island for 4 months. But what I have noticed is that the vast majority of their students go on to clinical rotations before they take step one. And if you're already no AUB, American University of Barbados. So if you're still in basic sciences, if you're still in block 8, I would say do everything in your power to take step one before you get to rotations because, again, it's very hard to make a good impression on rotations if you don't take step one. There's not much point in rushing through everything because just look at it mathematically. Let's say you finish. I don't know if your school allows this. If it doesn't, then there's no point even having this discussion. But a lot of Caribbean schools will let you do your rotations before you take step one. It is. It has never been a good idea that I have seen, and so you get to rotations. While you're in rotations, you're worrying about step one prep instead of paying attention to learning clinical science, clinical knowledge, which comes in like you need it for step two. Not just you need it for step two, you need to pass the rotation. You need it to make a good impression on your attending, so they'll give you strong letters of recommendation. You're going to need 3 to 4 letters of recommendation. Let's say, I applied internal medicine. You want at least 2 letters from the specialty you're applying to. And so that means you have to make good impression on at least 2 internists, and then let's say maybe 1 letter from family medicine or surgery, and like it's fine if you have 2 letters from your desired specialty, but again, hard to make a good clinical impression if you have struggled with step one. It's actually something that used to piss off attendings when I did my rotations. Is students kind of being like, you know, I'm studying for step one, so I can't come in on this day, or I have to leave early, or anything. They just didn't want to hear it because generally it translated into poor performance on the clinical rotation. So I can't stress it enough. You're going to spend the time anyway. Even if you run through basics and clinical sciences and you complete your degree in 4 years, that's like yay. But then you're still going to sit down and spend that 6 months doing step one prep. So like mathematically, you've gained nothing, but then you've lost a lot by screwing up your performance in clinical rotation. So there's not really any good reason to do it if you can avoid it. If you're already doing it, I have a lot of friends doing it, and it's kind of like, okay, make the best of the situation that you have. But if you're still in basic sciences or studying for step one, please try and take the exam before you get to clinicals. So moving on from there, yeah, it's the same thing. Step 3 to 12 months. There's 4 things you're going to have to get right when. It's 4 things you're going to have to get right when you're doing step one or step two prep. So when you choose the material you're using, that's always the first step, is choosing material that you can trust. But then the 3 that come after are the most difficult ones. So, like when I have students I'm coaching for step one, it's very rare that I'll sit down and discuss content with you because it's like, yeah, I can, if you want me to teach you EKG, I can. If you want me to teach you like all of cardio, I can. But that is so many hours that it will take, and so to maximize the value that anybody gets, that you can get, that I can get out of that time we spend together, it's more about strategy. So mastery is like when you study, by how much has your understanding increased after you study. So a lot of people, let's say there's if you're using Sketchy to study micro, let's say you're using Boards and Beyond to review for step one prep, or if you're using first aid to track your progress. A lot of people set the wrong goals. A lot of people set the wrong goals where it's like, okay, my goal for today is to do 10 pages, or my goal for today is to do 3 hours of video. And then they watch the 3 hours of video and then they feel good about themselves. But that, like, in and of itself is not even slightly helpful, right? What matters is that, okay, after you've done that 3 hours of video, by how much has your understanding increased? So a lot of the candidates that by the time they come to me is that, okay, spend a lot of time like doing it by themselves, and it's not making progress. So that mastery thing is like the single biggest issue for step one prep. So watch out for that when you're doing your own step one prep. Retention is another big issue where if you're studying for 6 months, let's say you take your exam by the end of the 6th month or the end of the 7th month. The stuff you studied in the first month, you need to remember it just as well as the stuff from that 6th month or 7th month. And so you need to really have an organized, effective way of building spaced repetition into your study plan such that you don't allow yourself to forget. A lot of people also make mistakes with that and would review, only after they've forgotten the information. At that point, you're really not reviewing anything, right? You're just learning it from scratch. And so working on that's another big thing. And then final is applying the information. So you've mastered the information, you remember the information. How well can you use it to arrive at the right answer when you have the step one star question? So those choosing materials is like easy. It's not anything. But mastery, retention, application, you really, really need to um, put efforts into making those good before you take your step one. So there's really three kinds of. Ignore this last line. The last time I presented this was I presented it to people that were in Nigeria. So ignore that last line. You're in the Caribbean, so you have testing centers that are close to you. You have testing centers in the UK, or even in your home countries. A lot of you will have testing centers. So just ignore that last line. But the required resources that you're going to be using, you'll need at least one lecture-based review. It doesn't matter what it is. It can be it can be Kaplan, it can be Lecturio, it can be Boards and Beyond, it can be Smash. I actually, even currently, I contract for a company called Smash USMLE. I'm sure you may have seen some ads for them on which one is best. That depends on the specific student. So, but I'll tell you that Boards Beyond, if you're studying for step one, Boards and Beyond is, I think, the lecture-based review that works best for most people. There'll be people for whom Lecturio is better, or Kaplan is better, or even the ones from the company I contract with, Smash USMLE, might be good. But in my experience, Boards and Beyond is the best for the highest number of people. So that's because it's concise. It's only 126 hours total, and it has like most of the information. If you master those videos, USMLE RX is too easy for step one. Yeah, I wouldn't say easy. I wouldn't say too easy, but I'll say definitely it's RX questions are not as rigorous as step one star questions, and even as UWorld. So for video, like I said, the best is usually either Kaplan or Boards and Beyond. Kaplan is designed as if you're aiming for like 250, 260, which is good if you are, but for a lot of people is not efficient. So then Boards and Beyond for a lot of people, which is still really good. Then for question banks you're asking, I would say that the top tier is two Q banks, UWorld and Kaplan, right? So would I recommend Smash USMLE? I mean, I work for them, so I would, right? I absolutely would. So the thing with Smash USMLE, Amboss is good. Yeah, I'll discuss all these one by one. The thing with Smash USMLE is that, like a lot of test prep companies, their focus is giving you actual content. So the Smash library of self-paced videos, excellent, right? The question bank, I'm not going to lie to you, is not the best, but the videos are really, really good. And the 4-week live hybrid masterclass is like perfect if you've had a good foundation and you just need a rapid review before you take your test. So that's like what's really good about Smash. Now, what I would say is the cherry on top. If you search Smash USMLE, you'll see it's the best. What's the word? Can't remember, but it's one of the top rated review resources. You'll see it on a bunch of websites. And me working for that company, I think part of it is because of big part of it is the coaching session. So Depending on what package you sign up for with that company, you'll get like 2 hours, 3 hours, 4 hours of coaching, and that is really helpful for you optimizing how you use the resources. Now, like Lord's Favor said when we started, I have my own operation that I've started, and what we do is entirely tutoring because, in my experience, people already have access to good resources, right? So, like I said, Boards and Beyond is ideal for a lot of people. Most people already have it. If they don't have it, they're willing to get it. It's kind of cheap for step one review. Everyone's going to get first aid. Everyone's going to get UWorld. So what you find out is that kind of like everyone has resources already, and so going with Smash, I would say the highest value you'll get from that, in addition to the coaching, the coaching you get from the tutors, then is the 4 week rapid review and the video library. Now, about the 4 week rapid review, I clarified that it's only really helpful if you've had a good foundation and you need that rapid review before your exam. But most people starting out step one prep don't have the foundation to take advantage of that 4 week class. Imagine covering the entire basic sciences in 4 weeks. It's a nice proposition, but a lot of people go into it with the mistaken assumption that when they come out on the other side that they'll be ready to pass the exam. Like, no, that's not what it's designed to do. I moderate those master classes, so I can tell you firsthand they're excellent when you need that rapid review, but not for the beginning. Divine intervention is good for, I would say, it's kind of like osmosis in that you can really learn a lot when you listen to them. But for structured step one review, I can't really say anything about them. I don't know much about them as like a source of, should I say, like video lectures. Yeah, so Amboss is good as text-based review. A lot of people would prefer to watch videos instead of sitting down and reading Amboss. Amboss is kind of like looking at a textbook, and some people like that, some people don't. I personally much prefer to read instead of watch a video, so Amboss is a good resource for me to use. But no matter whether you enjoy reading or watching videos, I actually wouldn't recommend Amboss as primary resource if you're studying for step one. Now, that being said, I recommend it to everyone that's studying for step one, but not as a primary resource, as something that when you're watching, right, for mastery, if you've watched a concept in a video and you've rewound, you've not understood it, and like, even if you see something you can't define, like they will say, I don't know, MHC1 for instance. Maybe you don't know what MHC1 is, and you need to look it up. Amboss is really good for doing that instead of going on Google. So I actually recommend it just because it's 15 a month. If you study for 4 months, or let's say you study for 6 months, right? If you study for 6 months, that's what, 90 USD you'll spend over the course of your step one review on Amboss. I would say it's good value for the money considering what you're trying to accomplish. A lot of people make the mistake of looking at step one and step two um, like a major purchase, the way you evaluate the purchase of an iPhone or something. But you know, the the value proposition is very, very different because think of all your tuition across your 4 years or 6 years at IUHS. Think of your salary as a resident and eventually as an attending. So it's like if you're already in this process, you want to maximize your chances of like coming on the other side, matching into residency, which like I said, we're going to look at specific figures, right? And in fact, we can look at them now while we're still on the subject. So I'll show you some notes that I made in the meeting. I'll show you some notes that I made. Here we go. I don't know how well you guys can see these figures, but down here is a summary of the 2022 March figures, and up here is kind of some information about this cycle that I just went through. So let me actually copy it into Word so that it would be bigger. I don't know if that text is too small to see right now, but yeah, like I said at the beginning, this is what you're looking at when you do your when you're studying and you're thinking about like how to review. Let's start from up here at the match rates. Yeah, Amber's question is pretty challenging. Let's look at the match rates, right? So there's four classes of match applicants. I fall into this category, right? Non-US IMG. A lot of you will also be in this category. Some of you might be in this category, US IMG. US IMG means that you're either a US citizen or you hold a green card. Especially, essentially, you don't have to be sponsored for a visa by the program, right? So there's two classes of visa, J1 and H1B. The extra paperwork that you have to go through if you need a visa is much, and programs don't always like dealing with it. Programs don't like dealing with it, so we are as non-US IMGs at a slight disadvantage. Please, I'm in a meeting. Sorry. Yeah. So the match rate for USMDs, is 94%, right? So 94 out of every 100 of them will match. 92 out of every 100 US deals will match. If you're a US IMG, your chance of matching is 67% or 68%. And if you're a non-US IMG, like myself, there's a 60% chance that you match, which means there's a 40% chance that you won't, right? Now, that is a big percentage to be dealing with. Like, 4 in 10 chance that all the time and effort and like sweat and tears and cash that you put in this process does not pay off is much. So that's why I'm harping on this so much. So this is a summary of the 2022 match, just because the charting outcomes of this year's match are not um, some of the data is out, but the full charting outcomes is not. So this is just notes from last year's match. You'll see that for PGY1 spots, which is first year residency spots, there were 40,000 total applicants. Now, out of that 40,000 total applicants, it's going to be something like, I don't know, 38,000 active applicants. And you have to be careful with that number, because when the NRMP calculates these figures, 67%, 60% chance of matching, they use the active applicants to calculate that, not the total applicants. And what I mean by that is a lot of the active, to define an active applicant is just somebody who had a rank list when they applied. And the only reason, or like the major reason, why somebody would apply to begin with but not have a rank list is because they didn't get any interviews. And that happens to a lot of people. So if you factor in the number of IMGs who don't even get interviews to begin with, this number goes down even lower. So you have to be really careful about that. But yeah, the number of IMGs US that match is 3.1. Number of non-US is 4.6. But yeah, if you factor in the number of people who didn't get interviews to begin with, this starts looking more like 54%. And the fewer interviews you have, obviously, the less the chances. So yeah, let's move on from there. That's why I'm harping on, when you do your step 1 and step 2 prep, you have to get it right, because you literally your future. So the video reviews different for everyone. The text-based review, most people will use first aid. The question banks, most people will use UWorld. Now, when I was saying about UWorld, that the top tier Q banks are UWorld and Kaplan. Personally, when I did my step 1 prep, I went through every question in both of those Q banks, because I paid Kaplan for my own step 1 prep at the time. So I did all of Kaplan's questions, I did all of UWorld's questions. And what I'll say is that they will prepare you equally well for step 1. The only difference is that the way in which Kaplan is written, that's the explanations. The way Kaplan explanation are written is as if everyone who's using the Q bank is aiming for 250 and above on step 1, which is not true, right? 250 is the 85th percentile, so only 15% of people will score that and above, when there was a score anyway. And so it's very detailed. I liked it for that because I was going for 250. But if you're not, and a lot of people aren't, a lot of people will be happy with 245, 240, even 230, right? For the vast majority of people, UWorld is by far the most efficient Q bank because the explanations are shorter, more concise, straight to the point, will give you what you want, what you need, but not much else. So those are the two top tier Q banks, and depending on how much of a gunner that you are, is all determine what you use. And then after UWorld and Kaplan, now you have Amboss, RX, Lecturio. Um, After UWorld and Kaplan, I would say Amboss is the best. And the reason for that is that that integration with the library that they have going on is excellent. I personally still use to this day. I use Amboss as a study resource. I'm studying for my step three. I'm not studying from Amboss. I did that when I was in clinical rotations. I use it as my primary resource, but now it's something where I can easily look up questions, and if I'm coaching students, we can do practice questions from there. So yeah, I still have an Amboss subscription. It's pretty good. And then like Turio, it's okay. Smash, it's okay. All the other ones are kind of like just there. So if you're looking like if you're only going to do one, do UWorld. If you're going to do two, I would say UWorld and Kaplan or UWorld and Amboss. If you're going to do three, UWorld, Kaplan, Amboss. RX is there are not many conditions where I would recommend RX as the primary Q bank for someone. I once had a student that had gone through every Q bank. That's like she had seen all the questions in UWorld, she had seen all the questions in Kaplan, she had seen all the questions in um, Amboss, and so yeah, it's not helpful to repeat questions, right? You end up not thinking critically. You can't just remember the answer from last time. And so I said, okay, hey, now that we've adjusted your approach to mastery and retention, we need to switch you to a new Q bank. So for her, I did recommend RX, but outside of cases like that, RX is like if you already have it, yeah, use it, but don't go out of your way to get RX. And so that's for QBank. And then you have the auxiliary resources such as Sketchy, Pathoma, Amboss. Um, Pathoma is excellent if you need rapid path review, Sketchy for micro, Amboss for looking stuff up. Um, Coaching is only for certain people. It's like if what you're doing is yielding results, then by all means, like just keep doing it. But a lot of times you'll find, okay, I've been studying for 3 months, kind of nothing to show for it. Say you take a self-assessment at the beginning, you took one after 3 months, and you've not seen like any movement, or you've seen movement and it's not enough. That's like you should consider coaching. Or if you're already like you've been struggling from before, then like I said, this is your future you're dealing with. It's 40 to 50% chance of not matching. You don't want to be in that 40 to 50%. It's not pleasant. And then the pass fail is, yeah, like I keep harping on, for IMGs, you have to pass the first time. A lot of programs that I applied to had it on their websites that, you know, like you have to pass on the first time to qualify. And again, I don't think it's most programs, but it's a very high percentage of them. Maybe 30%, maybe 40% will say that if you didn't pass the first time, like don't even apply to the program. And the ones that do consider you, some of them will still filter a candidate like that out. If you will still look holistically, and like thank goodness that there's programs like that, because a lot of people do go on to match with an attempt. But if you look at the statistics are already poor. 60%, that's not good. 50% is not good. It's already poor, assuming you've done everything right. But if you've had a failure, it becomes exponentially more difficult. But for someone, let's say you failed the first time, then you're allowed to take it 4 more times. Again, you don't want to do that, and oh, my bad. I didn't strictly speaking stick to time, but we're almost done. We just have 5 slides left anyway. So yeah, we've said the most important things that there is to say. Go ahead and go ahead, Marvel. Absolutely, if you have to. So yeah, for a candidate, let's say that failed the first attempt, while it's possible to go ahead and match, you just have to know, okay, what are the things you're doing to make up for it, which is like aggressive networking, doing more and more research, more clinical experience, and it's raining heavily outside. So if you guys can hear the rain through my microphone, just put it in the chat. I'll switch to a different microphone. That's fine, right? So Yeah, you have to pass all the steps within 7 years for to get licensed in most states. Most people will pass within 7 years. That's no big deal. Now, this is a big thing for step two. And when step one had a three-digit score, it was still a big thing. Where if you didn't pass, if you've passed, even if the passing grade is 196 and you get 197, then you can't reattempt the exam. I think at least for 7 years. So I've had, I know, I have a friend who he was in my old school with me, and he passed, but his score was below 200, and I don't know why he decided to go that route. But he essentially left the school. He went to school in Ukraine. I think his plan was not to approach the U.S. anymore. And if you're not approaching the U.S. anymore, it's not. Yeah, Caribbean schools are kind of really expensive comparatively. So, but yeah, passing a USMLE with a bad score, um, the score follows you for life. So I always say be really careful about taking your self assessments and knowing where you stand before you take the exam. It's not something. It's not if you've already gone through it, then there's nothing much to change about it. But if you're still in the basic sciences, for those of you who are still in the basic sciences, you have ways to know where you stand before you take the exam, which is the NBME self assessment and is the UWorld self assessments. They're really accurate. Not UWorld, NBME. UWorld is accurate on step two. NBMEs are best for step one. So they're so accurate that for a lot of people, the points you get on test day will be just within a few points of what you do in your assessment. So, like my last assessment before I took step one, I scored 252. On test day, I scored 254. My last step two assessment, I scored two 262. On test day, I scored 260. Do they repeat questions? That's a tricky question to answer. So yeah, you might get a question, and if somebody comes the next day to take the exam, they might see the same question, but they randomize the questions. So even if you and someone else are sitting side by side taking the exam on the same day, you and them might see two different sets of questions because there's a huge bank of questions, and they draw questions from them and test you with them, which is why they don't give you a raw score that says, oh, you scored 67% or you scored 80%. The score they give you shows how your performance was relative to everyone else who took that same set of questions, right? So let's say on your own block of questions, average score is 67, you score 67, you'll get an average score, which is on step two is 245. But if somebody else, the average score, maybe it was a really difficult set of questions. Yeah, exactly, similar. A really difficult set of questions, and the average was 55. You scored 55. Because you were average, like right in the middle of the pack, your where you land on the scale will be similar. So that's why it's fair at the end of the day. But yeah, repeating questions, whether they do or not, it's not something that's likely to be useful, especially because I don't know if you already know this, but it's a big violation to reproduce questions after the exam or to seek for reproduced questions. Literally, this cycle I just applied in, there was some lady in the Facebook chats asking for advice because she was on some board, some forum, and she was asking about previous step one questions, like who had, I don't know what she was asking, but it was a clear violation of USMLE policy, and she was unfortunate enough to do it with her actual email address, which was linked to her USMLE ID. So they flagged her, and she could not match because of it. Literally, she had program directors tell her that they like her as an applicant, but because of this gigantic violation on her record, they can't match her. So be careful with those repeated questions. Um, and then after you take step one, step two, these things you do them more when you're in clinical rotations. All right, when you're in clinical rotations, personal statements comes in the year you apply. So if you're applying to apply, let's say this year, from like June, July, you want, maybe not that early, but early on, you want to start thinking about your personal statements. Research is really important, especially if you're trying to apply to a competitive specialty. Now, these days, the lines are becoming more and more blurred on what's competitive and what's not. I mean, for sure, you still have the things that are like heads and shoulders above everything else, like plastic surgery, ortho, derm, stuff like that. That's like highest level of competitive. But everything else is kind of blurring. Where before psych used to be, it was a joke in the US that like if you failed all your rotations in med school, you went into psych. That's not true anymore. The demand for psych is going up. Mental health is a big deal. The lifestyle is good, and money is good. So it's been becoming more and more competitive, where they're trying to select for people that have demonstrated a clear interest in psych. Emergency medicine used to be one of the most competitive specialties. In fact, at the beginning of my clinical rotations, I was considering doing emergency medicine. Um, I ended up not wanting to do it, but this it used to be so competitive before, but this year they had 3,000 spots, and for it was the only specialty in the match where sure I won't. It was the only specialty for which there were more spots than applicants. Now think about that, right? Like an entire sub like specialty for residency, and the number of residency spots, like there's fewer applicants than that. So obviously it became slightly less competitive. People don't want it for a bunch of reasons that we can't even start discussing in this session. That's like a whole different session. Yeah, but they had 550 on field spots after the match, which is a huge deal. After soap, which is something else, they filled 500 of those spots. But the fact that they had 550 on field spots is it's not a good signal for that field. And so, but that used to be when I started med school was one of the more competitive fields. Internal medicine used to be like by default you go there as an IMG, but that's becoming more and more competitive. I had a very competitive application. I only got two interviews, right? Um, which I'm still grateful for the two. One is where it's a program I really wanted to go, which is where I eventually matched. The other one I was not so keen on, but I was still grateful for because it was an interview. But like I said, I had two interviews, and that's I had a competitive application. So you can see that even the ones that you kind of view as not so bad are not so competitive, are becoming more and more competitive. Yeah, chance of matching with two interviews, if you're interested, the probability is 33%. And for me, as a non-US IMG, with like I hadn't had my ECFMG by then, I hadn't even graduated as at the time I applied. Bro, two interviews out of 94 applications. So that's yeah, I wanted to apply to like 180, but like I said, I wasn't ECFMG certified as at the time I applied, and for about 80 to 100 programs, I wanted to. Yeah, I'll be starting residency, not rotations, in July. So for about 80 to 100 programs, I was really wanting to apply to. I couldn't even apply because on their website they said your ECFMG certificate you need to have it before you apply. Now most IMGs do, like I said, I didn't because I was still in my final rotations as at the time I chose to apply. So fortunately, out of the 94 applications I could apply to, there were four that I really wanted to go to, because they're in Chicago and I really wanted to be in Chicago and I wanted a university program. So that was those four programs. And yeah, out of those four, one offered me an interview, and then the other one was in New York program I didn't really want to go to, but yeah, so out of the two interviews, yeah, I matched at the one I wanted to go to. That's I'm just telling that story to show it's kind of lame, but I was wondering if the USMLE is the hardest. Thank you for your congratulations. As for being the hardest, I would say that it is not because I've taken exams in other countries, but based more on the fact that for people who research difficult exams, if you just go on Google and look for most difficult exams in the world, you'll find the USMLEs on quite a few lists, and but you won't see licensing exams from other countries. So I think that that says something, and the fact that it's an 8-hour full day exam that tests your stamina. Literally, I had someone that she was telling me on her test day that she had a block. She felt like crying during the block, so she took a break after that block and went to the restroom to clean herself up. And she was crying, and then she said she met another girl in the restroom there crying. So step one kind of does that, and that's even when you're well prepared. If you're not well prepared, it's a problem. Yeah. So, but anyway, coming. Thank you, thank you, thank you. Yeah. Anyway, coming back here, you really want to keep an eye out for research experiences when you're going through rotations. This, I think, is one of the most difficult things for us IMGs because step one, step two, your grades, your performance, like you have so much control over a lot of things. Publications is something that's more difficult for you to control because it depends on, is it possible to take step two before step one? It used to be possible. I don't know if it's still possible, but I also would not recommend it. I don't know when you joined, but I was explaining how a step one is about 30 to 40% of the material on step two. So the only way to be well prepared for step two is to have a strong step one foundation. And if you have a strong step one foundation, you might as well take it before step two. There are very few situations, if any, where it would be a good idea to take step two first. I can't even think of one. So yeah, if you have a peer-reviewed publication, especially if you're first author. Oh yeah, I didn't answer that Q bank question. It's not Q banks. It's the NBME self-assessment, right? So you go on mynbme.org. You can sign up for self-assessments. Each one is 20. It's $20. Save them. Don't like run through all of them. Do one before you start your prep. Do one like a week or 2 weeks before your actual exam, and then one or two in the middle. Yeah. So for step one, NBME is best. Amboss does these free assessments in like February, March. It passed for this year, but if you have to do next, like if you're taking your test next year, yeah, absolutely, you can take advantage of that. Amboss free assessment is pretty accurate. I would say use UWorld only if you've used up the other ones because it's not as accurate for step one. But on step two, it is really accurate. So UWorld and the NBMs are really good on step two. So yeah, publications, peer reviewed publications are best. The best ones are where you're first author. Second best is when you're still peer reviewed publication, but you're not first author. After that, you have poster presentations at conferences or oral presentations at conferences, which is an even bigger deal. This is actually the only research I had on my CV, as at the time I applied, I had 3 poster presentations at conferences in the US, and I did try to get a publication before I applied, but it got rejected from like 3 or 4 journals before yeah, so I couldn't put it on my CV, right? It didn't help me. But yeah, it's peer-reviewed publications are more difficult to get, but if you get them, they count more. And then poster presentations are still good. Like I said, that's all I had. And then even if you don't get a poster, but you have some kind of research experience, it's still better than having no research experience. People do match with no research experience, but they are the exception, not the rule. Maybe they know someone, or I don't even know. It's rare that you see someone applying and not having research, even if it's like IN or FM. US clinical experience, we don't have to go over because probably you're all going to have US clinical experience. But yes, they strongly prefer if you have it. That's something that gives us a big advantage over IMGs from like every other part of the world because we do our rotations in the US as Caribbean students. US letters of recommendation, I wrote not strictly required, but strongly preferred. But that's not. I'm not sure anymore if that's true. They really, really, really want your letters of recommendation to come from practicing physicians in the U.S. In fact, someone was talking about. Excuse me. Someone was talking about the letter of recommendation was written by a Harvard-trained physician researcher who had gone back to his country and was practicing in his home country. And he wrote the letter of recommendation. And when they tried to use it, the program directors were like, it doesn't count because it's not from someone practicing in the US. And so that just goes to show you that, it's not like they're, I don't know how to put it. They just want your letters to come from the US. That's just how it is. And then right now, this does not affect you guys really at all. But when you request for your letters of recommendation, they're going to ask if you waive your rights. Always waive your rights. Waiving just says that if the doctor writes the letter before he uploads it, you won't have any chance to see it. And so what that means is that you kind of have to trust that what they're writing is good for you. And it's not always the case, especially if you've waived your rights. Program directors want you to waive your rights because it allows the physician writing the LOR to be honest in their evaluation of you. Now, if you wrote your own letter, that's a different thing, which happens a lot of times for IMGs. Like I uploaded 4 letters. Out of the 4 letters, I wrote one of them. Now, when I was filling the form, I still waived my rights because, as far as any program knows, it's the doctor that wrote the letter. But the other 3 physicians I asked for letters of recommendation. Each of them wrote it by themselves, and to this day, I have no idea what was in the letter. If they're nice, they'll like send it to you outside of the ERAS process. But you know, if you're very close to them, you can ask. If not, it's like you should just even be grateful that they're writing you a letter to begin with. Now, that harkens back to what I was saying about you have to perform strongly in rotations, because if you don't, they're going to put that in your letter of recommendation. And forget bad letter of recommendation. An average letter of recommendation is like, like a mediocre is like, it's not like showing that the attending is impressed with you. It might be worse for you than not even having a letter of recommendation to begin with. So that's why the only LORs that count are strong LORs, and so you need to perform well in rotations to get those, and you need your step one to do that. So yeah, that's going back there. Connections are helpful for getting interviews. I don't know how helpful they are for matching. Once you get into the interview stage, you're kind of like on level playing field with everyone. Not necessary. Actually, I take that back. I take that back. Let's just talk about the connections helping you getting interviews. If someone knows you, like a resident that's already in the program, and they're like, I've worked with this person, their clinical skills are good, they can take instruction, they're nice to be around, like they're friendly, they're empathetic. If someone can vouch for you, it helps to get interviews. Now, the 2 interviews I got, I didn't know anyone at the program, and the 2 people I knew that I could ask for connections. One I did ask is a program I might have liked to go to, but it was in Baltimore, not in Chicago, so it was like lower down on my preference list. I did ask her to recommend me, and she did recommend me, but I didn't get an interview. Another one, he offered to recommend me, but I actually, this is where the connections can get interesting, because I asked him to not recommend me. He's a very close friend of mine. I asked him to recommend another friend of ours that I knew that she didn't match last cycle. Now, I kind of miscalculated at that time because my application is pretty strong, so I figured that I could get a ton of interviews without help. So I told him, don't recommend me, recommend this friend of ours. So he did. Funny thing, she got interviewed there and she matched there after not matching last year. Now, I've never discussed this with her. I don't know if she knows that that's what happened, but yeah, she's going to be at that program with him, and that's like, it shows that the connections can help you. In this case, it was indirect because I didn't recommend her, but I did ask for this guy to not recommend me, recommend her instead. So it definitely can help. But he going into that program didn't know anyone there. Me going into the university where I'm going, don't know anyone there. And 5 other friends that I have, all the programs that they've all matched to, none of them knew anyone there. So the connections, they help, but your application is all do the talking at the end of the day. So she, like, yes, I did have him recommend her, but she did a lot of work between last year when she didn't match and this year to make herself more competitive. I helped her to write her personal statement and letters. It was just a bunch of stuff. So what I'm saying is that the connections help, but you have more control. Your step scores as well speak for you. Your letters of recommendation will speak for you. You know, Connections will not help you if your application is weak to begin with. So when the time comes, you can do program research through. Um, there's match a resident. They'll make you pay. Don't pay for it. It's not worth it. When you sign up to start doing ERAS, you get an ERAS token and everything. Once you pay for that, you'll get access to a site called Residency Explorer. Everything you want to know about programs, not everything, but the most important things you want to know about programs, they they can be found there. You don't need to pay for match your residence. I did. My friend warned me not to do it, but I did it anyway. I didn't benefit one single thing out of it. So yeah, I'm telling you the same thing. Just stick to Residency Explorer. It's much better. And everyone I've spoken to, I know a bunch of people that have gone through the process. There's nobody that has uh that would be like, oh, they pay for match resident again. Residency Explorer is good enough. You'll apply through ERAS, and for an IMG, you're going to want to have 100 to 200 applications. I wanted to have in like the middle of that range, 150 to 170. Like I said, like about maybe 80, 90, 100 programs. I don't remember the number. I wasn't ECFMG certified, so I didn't have. So I applied to 94, but I matched, and where I wanted to match too. So it's all good. Advice on observerships and virtual rotations. Observerships is better to have than nothing, but they will not count much because they're not hands-on, right? So now there's a lot of ways in which like there's loopholes. Something will be listed as an observership. You might go there and end up doing hands-on work, and if the doctor is asked about it or like has to write an LOR, they might vouch for it being hands-on, and that means if you apply, you can put it as hands-on. But like strictly speaking, if you put an observership in your residency application, it doesn't carry as much weight as an actual externship. In externship, you get hands-on experience with the patient. How does one get certificate? That's not even a thing to worry about at all because it just says that, oh, this person went to this med school outside the US and is qualified, and so for you to get that, you have to pass step one, pass step two, pass. Before there used to be step two CS, now it's OET. So pass step one, step two CK, pass OET, and then have your final medical diploma, which means you have to graduate from med school. So once you've graduated and you've passed all these exams, you just go on the website, you apply, you get it, right? So for me, like I said, the issue was just the fact that I was in my last couple of electives when I applied. So I hadn't even graduated yet. So it wasn't possible to apply for ECFMG. So, but most IMGs will graduate first. They'll have ECFMG, then maybe they'll study for step one, step two. Yeah, so you do 100 to 200 applications. Most people I know did in the vicinity of 150. Some people 175. And if your application is good, you will get somewhere like, I don't know. A good number of interviews to have is like 12 and up, because above that number, it's like 90 something percent chance of matching. If you have one interview, it's like, I don't know how many percent it is, but I know I know two interviews, because that's what I had. It's 33% chance of matching, which means 67% chance of not. So the more interviews you have, the more likely you are to match, and yeah, you get more interviews by just being more competitive on paper, which is step scores, and yeah, connections can be helpful, absolutely. Then J1 H1B visas is, I don't know how many of you have US citizenship or green card, but if you're like me, you don't have that, you're going to need to be sponsored on a visa. Just to summarize them real quick, the J1 is considered an exchange visa. So it's not dual intent visa. You're not allowed to want to immigrate while you're on the visa. But that's a technicality, because anyone who's trying to do residency training in the US wants to immigrate to the US. So the J1 rule is that when you finish your training, you promise to go home to your home country and work for 2 years. Only after that 2 years can you now immigrate to the US. So that's that requirement. But there are some waivers that allow you around that. Typically, you would have to agree to work for 5 years in a medically underserved area, which many IMGs are more than happy to sign. And then for H-1B visas, that one is considered a dual intent visa, where it's like, okay, you might be wanting to immigrate, can lead to an employment-based green card. So a lot of people prefer to go for the H-1B visas, but fewer programs sponsor them, like relatively few programs sponsor them. And for you to even be eligible for it, you have to take step three. Now, me, I haven't even taken step three. Most people take them in their first year of residency. I'm planning to take mine in June, just before I start residency, so I don't have to worry about it when I'm a resident. But for you to take step three, you have to be ECFMG certified, which means you have to have graduated from med school. That's different from step one and step two CK. You can take step one and step two CK as a med student, but for step three, you have to graduate and you have to have your ECFMG. So, yeah, if you have step three, you can apply to H1B visa sponsoring programs. Like my closest friend, she's on a H1B visa. But something I've been hearing recently about these visas is that J1 visas are better for doing fellowship. I don't know how true that is. I don't know what would be the challenge with doing a fellowship on a H1B visa. It's never applied to me, so I've never looked into it. But yeah, me, I'm interested in doing a cardiology fellowship after internal medicine. So if it's true that I don't know, but if you're considering, those are the things to look into. When will you need to graduate? When will you have ECFMG? When will you take step three? How much do you care about being on a H1B visa? Most people come in on J1, like myself, and yeah, you can do the waiver. I think there's one or two other ways to waiver it, but yeah, most people come in on J1. Now, regarding cost, um, where are we at? Okay, I don't know what has happened here, but hold on a second. There we go. Yeah, so again, ignore the last slide in these USMLE exams because I made this table for people who were in Nigeria at the time, and the closest testing center is Ghana, so just ignore that. But all the other exam fees are the same. You have to do an ECFMG application, that's 160, exam is 925. The rest of these expenses are variable, but you can expect to spend somewhere in the vicinity of 2,500, maybe 3,000 or more. It depends. Um, Prepping for step one. The only, like here where I have other resources, I put 300, and that was assuming that somebody only was going to use, let's say, UWorld or like Kaplan, um, no coaching, right? Obviously, if you want coaching, the expenses go up, but that depends on you, your own strengths and weaknesses. So, like, I think I paid Kaplan something like 7,000 for step one prep. The resources at the time, should I say there were things I wish I knew then that I know now? 7 grand is a lot to spend on step one prep, and even after, because it expired, I still had to do an extension, paid another 1,500, so I spent 8.5. But I mean, I'm okay. I'm happy with it. I scored well, so it's worth it. But these days, if you cobble together resources without relying on one company, like you get your videos from boards, you get your QBank from UWorld, get your first aid from, you can even like download it or just buy it online. You can prep for lots cheaper, and then that allows you, if you need help, to even budget for coaching, which some people will require, some people will not. So that's for step one prep. It's a similar figure for step two prep. Step two prep is just a little bit more expensive than step one prep. Not yeah. And then there's OET, which is a $450 exam. After you do OET, you'll apply for an ECFMG pathway. When you apply, that will be 925 to apply. So total for OET is around 1,400. Um, USCE does not count because for you guys here, that's going to be part of your curriculum anyway. So you kind of ignore this for now. I guess only if you're interested. Nah, just ignore it. Residency application, if you go ahead and apply to 150 programs, then if you apply to 150 programs, you'll end up spending around um 4,500 to apply for everything. There'll be a few other expenses that come up, but it'll be around this range. And then step three, you have to travel to the US to take step three. So prepping for it will come in somewhere around 4,625. For me, it's coming in. Um, I'm not even sure because I'm again using Kaplan resources, but that's just because they were free. If you did well on step one, Kaplan gave you free resources for step three. So I had some data in here I wanted to show, and I guess I went too far back into the version history. So let's see this one. We've already gone over most of the important NRMP data. That's like the match rate, the number of applicants, and everything. But I just want to show you guys a couple of graphs. Here we go. So this graph here is showing your probability of matching into a preferred specialty when that preferred specialty is family medicine. Now, down here on the x-axis, you have step one score. On the y-axis, you have the probability of matching. This is obsolete because now there's no step one score. But the reason I'm showing it to you is that there's no similar graphs yet for step two, because before step one was like everything. But there's no similar graphs for step two. But like I said, your performance on step one is anyways correlated with your performance on step two. So, but yeah, so looking at the graph, you'll see that blue is for US IMGs, green is for non-US IMGs like myself. And so let's take the average step one score, which that time was 230, 229, 230. So that's around here. You trace this all the way up, you'll see that for the average IMG, the probability of matching into family medicine is 60%, whereas the probability for US IMG is closer to 75% at the average score. So you can see like this, the gap between these two lines illustrates the advantage that people who have green cards or have citizenship have over people who don't. So yeah, that's a factor to consider. Years spent in med school and residency match chances. Yeah, so generally, if your program is 4 years, residencies want to see you finish in 4 years. That being said, if there's factors that were outside of your control and you can show that they were outside of your control, they're often willing to overlook that. So like I had a big transfer. I had a transfer between schools. I had years long gaps. I mean, I started med school in 2016. I had visa delays. One visa delay kept me in Nigeria for a year. Another one, the COVID delay for 5 months. Another one, step one prep, which like everybody has to do. And so I was also held back a semester, not because of like I failed a class, just because of paperwork essentially. So that's different than, okay, let's say if you've failed like several semesters and got held back because of that, it becomes a little bit more difficult to match from that. It still can be done, and that's a good thing is that for the programs that screen you out with computers, there are a lot of programs that will truly look at your application holistically and be like, okay, this person had these difficulties, and if you can show that you really truly meaningfully overcame them, then they'll give you a chance. But you can see that a lot of people don't get that chance. It's like once you've had that problem, if you're screening thousands of applicants, like you're looking for the smallest reason to take somebody out of the pile. So if you can avoid it, you really, really should do everything in your power to. But if you can, then you have to work extra hard. Like if it already happened, you have to work extra hard to make up for it. And then this is a similar graph for internal medicine. It's very interesting to me that the probability of matching with a low step one score was the same for IMGs, like non-US IMGs and US IMGs. But then as the scores increase, you again see that gap manifest itself at the average step one score. The probability of matching into internal medicine is somewhere around like 57% thereabouts. And then for For US IMGs, it's still around 75, 73%. So yeah, IM is a little bit more competitive than family medicine, but yeah, in both cases, the higher your scores, the better your chances. So let's look at like my own scores now. I scored 254, so that'll put me somewhere around right here. So that gave me about a 72%. No, that's family medicine. That doesn't count. Uh, my step one score puts me somewhere around a 77% chance of matching into internal medicine. But that's just based on step one score alone. There's all these different variables that go into um, IUHS, almost impossible to finish in 4 years. Yeah, most IMGs will not finish in 4 years. That's what I'm telling you. I started my med school July 2016. So count it, right? From 16 to 17, 18, 19, 20, 21, 22. Oh my goodness. It took me almost 7 years to finish a 4-year program. Again, none of the delays was my fault, but yeah, if you can show that it's like prepping for an exit exam, you had like family issues or finance issues. I did have finance issues at a certain point. Nigeria was in a recession in 2016, so that affected a lot of people. So for things that are generally outside of your control, programs will live with it. Like all my friends, I did 7 years, but my fastest friend finished in 5 years. Another one, 6 years. I've done 7. Someone's going to do 8. They still very well may go on to match. So yeah, the gaps don't help you, but if you're a strong applicant, they won't hurt you very much either. So this is also some more. I just picked a few figures from. These are two of the most popular specialties with IMGs: family medicine, internal medicine, and then I put surgery just as one of the more competitive specialties that IMGs apply to. So you'll see that the total number of people applying to internal medicine is the highest because it's like the biggest specialty, and the number of people that match in internal medicine is 59%. The percentage that didn't match obviously is 41. You can see for surgery, right? The percent of applicants that applied to surgery, less than 1 in 3 got in, and that's not even accounting for IMG versus non-IMG. So this is showing the number of contiguous ranks that each applicant had. So the average candidate who matched into internal medicine, they matched with 7 interviews that they ranked. Those who didn't match had an average of 2.7 interviews, which is close to what I had. Right, I had 2 interviews. Where do you show that? Yeah, absolutely. In the personal statement is where you can talk about challenges that you faced. And these days they've added something. My class, this last cycle was the first to have. It's called supplemental application. So in addition to your personal statement, which is limited to like 700 words, it's very hard to like show who and what you are as a human being and as a physician in 700 words. But that has been the challenge. And then, but this cycle they've introduced supplemental application, so you get even more chances to talk about gaps and like meaningful experiences in life to you, good or bad. Yeah. So um, anyway, that's that. You'll see that average applications for the number of average applications or publications, sorry, for those who match IM was 5.8. For surgery, look at that, it's almost 20 publications, right? And surgery, the more competitive the field, the more research you have to do. People in the US will literally take an entire year off of med school and will spend that year doing research. They might do it after the second year, they might do it after the third year. Some of them will even like defer graduation and do it after year 4. But yeah, if you want to march into a competitive specialty like surgery or OB-GYN, this is what you're looking at. Even the OB-GYN attending I had when I did my rotation was telling us how he did 500 deliveries in his home country before he came. I think he was from Syria, or I don't remember. I know he was from Syria, but I don't know if that's where he trained. But either way, he did 500 deliveries. When he got to the US, meant absolutely nothing to them. So he said he spent 2 years, I think, doing research at one of the most respected OB-GYN places in the country. And the funny thing is that even at that program, where like they liked him, he worked with them for 2 years, like he got to know them one on one. Like they still told him that um, they're not going to match him, but that because of course they reserve places like that for certain people, if you know what I mean. And so, but that the experience he got from there, the publications, and maybe even networking that he did from there, that's what helped him to eventually match OB guy in at a different hospital. So, um, yeah, a lot the average like the typical thing for IMGs is family medicine, internal medicine, pediatrics, pathology, and neurology. Those are the five most like popular specialties with applicants. Any idea of match rates for PEDS for US IMGs? I don't know the specific percentage for PEDS US IMGs, but PEDS is, how should I say, is one of the more common ones for us IMGs. So it's like if you apply to PEDS, I'm not going to say it's easy. Nothing's easy to match into it, for goodness sake. But it's like you kind of have a good chance. That's how I put it. Psych has been getting more and more competitive these days, and more US students are becoming interested in psych, which obviously, um, there's a fixed number of spots. So the more US students go anywhere, the fewer IMGs that place will be able to take. Psych is seeing that happen right now. Especially because since they merged MD and DO programs, before in the US, DO students would kind of go to DO residency, like, or, kind of things, but now DO students can apply to MD residencies, and they keep opening more and more of them every year. More MD schools, more DO schools opening every year in the US. So, because the number of spots is not fixed, to be honest, it does increase a little bit, but it doesn't increase as fast, I think, as the number of applicants. And so it's becoming slightly more competitive every year. Yeah, but IM, FM, PEDS, pathology, and neurology, they're kind of like forte for IMGs. If you want something like surgery, derm, ortho, plastics, you have to be prepared, kind of like, let's say you graduate and you start hustling really hard for experiences, connections, research, publications, and you know that you're going to spend like at least a year, probably 2 years of your life doing that if like you really, really, really want to match into that. So it's possible. It's just not easy. Right, so that's like the main takeaway from this. I mean, that's such a huge gap. Family medicine, right, 3.8, surgery 18.5, and that's even general surgery. Right now, you start thinking about neurosurgery, plastic surgery, because surgery is more accessible for general surgery is more accessible for IMGs, but those plastics, ortho, all those ones, like you'll see maybe one one IMG will match, and then that'll be it. So that is the end of my presentation, and so I know we've spent double the time that we were originally built for. I actually thought this was going to be kind of like you guys would unmute and ask, and I would answer. So these, as you can see, the slides were not optimized for today's session, for which I apologize. But yeah, if any of you wants to reach me, that's my email, bolu@adeyemi28@gmail.com. Ask me any ask me any questions, or yeah, just like reach out, and I'll get back to you as soon as I can. And then for now, does anyone have any questions? And you guys have been typing all your questions as we've been going along, but let's just give a minute or two, see if there's any questions at the end that you guys have. You can type them, or you can just unmute and say them. And if not, then I guess we can call it a day. Nope. Looks. I'm glad you guys found the session informative. So I'm going to stop sharing now.
Bola, can you put back the email address again, please?
Yeah, sure. Just hang on a sec.
Thank you so much, Bola. Thank you. We appreciate it. We appreciate. So that's it.
Yep, that's pretty much it. All right. Well, this has been really nice talking to all you guys, and I really hope that that helps some of you get more competitive for your residencies. So, work experiences worked against. Well, not really. I'll say they don't change much. If you have a lot of work experience, let's say in a research lab or like as a medical assistant, they might care about that. But a lot of work experiences are not, they don't impact your application one way or the other, especially if they happened before med school or they were not related to med school. It's the research, the experiences that will count will be research typically, and then after research, volunteering. Volunteering was something else I struggled to get because it was COVID time. Everyone was at home. Everyone was volunteering at that time, and so that's actually how this Baltimore Humanitarian group I did with my friend started. Because we just put money together and made a bunch of care packages and drove around handing them out to people in Baltimore, and then we just kept doing it. Then people joined us. Now it's like it's an actual thing, but yeah, volunteering experiences, you want to get as many of those as you can, and volunteering and research. That's those are the experiences that matter. You're welcome. How long can you use an LOR? How would the professor remember someone? Those are two excellent questions. So let me start. The first one: how long you can use a letter of recommendation? Um, Ideally, you would use it in the same year that you get it. So let's say that you rotate this year, you're thinking you'll apply next year. One option is to have the doctor write the letter for you with the date of next year's cycle, and you'll just file that and discuss with him and say, okay, um, yeah, that would be absolutely be a good experience. And discuss with the doctor and say that since you apply next year, he'll post dates by 1 year, and when you apply, you just use that. The big challenge will not be writing the letter; it would be, as you said, the person remembering you. So that that's definitely more challenging, honestly. So the way I handled that was that one of the letters I wrote, so that was fine. I just had to file it, and um, the, the 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 clinical coordinator person uploaded it on behalf of the doctor when it was time. The other letters I had, one of them I had just recently rotated, just a few months before I asked for the letter, and I had made a good impression, so I knew that the doctor would remember me. How I knew is because after I left, the other students that were still there would message me that this doctor doesn't stop talking about you, so that you will know that okay, he'll remember you, and he'll write you a good letter. The other one, I just kind of stayed in touch with him over time because between when I rotated with him and when I asked him for a letter was like 2 years ish, and so like Christmas I would message him Merry Christmas. Obviously he remembered. You have to make a good impression, right? You can't keep in touch with someone who doesn't have a good impression of you. So um, he, I know that we like really hit it off when I did the rotation, and so I'd message him Merry Christmas. Um, when I visited Baltimore, I went in to see him. You just kind of keep in touch and make them remember you. Other than that, you just ask people you rotate with closer to when you're applying. So, like if you're applying PEDS, for instance, schedule your PEDS electives for like close to when you're applying. Same thing for IM. Yeah, those are really the options. Keep in touch, write your own letter, or schedule your rotations towards the end. What resources do students use for LORs? Funnily enough, none that I know of. So about there are almost 20 websites I know of that do USMLE prep and coaching and all that stuff. Very few of them, some of them do personal statements. I haven't actually seen any that do letters of recommendation. So uh, now that's something I've done. I wrote mine. I wrote like for a bunch of my friends. and I have written for several people just that I met in rotation. So I've been trying to, I've been trying to, should I say, make it a more formal thing. So as Lord's Favor said, if you go on my website, you can like see what resources are available for that. So there's me, there's my friend. She has been chosen to be chief resident next year. So you know that okay, she knows what programs like how they think, how they evaluate you, and yeah, she's good with like writing. I'm good with writing, so that's one resource that's available. As for that, other than that, I can't really point to resources the way there's Kaplan and boards and Smash and other things that I can talk about. Now, you want to be careful about using an external service for your letter of recommendation and for your personal statements. I don't know what Interfolio is, but you want it to be from somebody that's medical. I can't tell you how many people I've written LORs or edited personal statements for that first paid 200 to some service, and because the people writing and editing are not in medicine, they don't, they don't know what program directors are looking for. They don't optimize the write up for that. So the work you get at the end is not what you're looking for. So if you get somebody to write for you or edit for you, just make sure it's somebody that's in the medical community, actively in the medical community, because they will know what details that you need in your letter. Listen, some people can write really terrible LORs. All right, any other questions? No, so I guess that we can call it. I will leave that up to Lord's favor.
What's the email again, please?
Oh, sure. Let me just type it in the chat. There we go. So that's the email and that's the website. Anyone else?
Thank you.
Yes, I have some questions here to ask you.
Yeah, ask it.
What is your own physical focus based on from what you have taught us now concerning IMG getting spot in high competitive specialty? Will it be grow up bigger or smaller, or will it be easier for us to get in or difficult for us to get in?
Okay, well, if it's a competitive specialty, those at their baseline are really hard for IMGs to begin with. And the trend with more MD and DO schools opening up every day means that it will just become more difficult. So you have to really, really, really push, if you want to go in those specialties. Be ready for the research time it will take and the networking you have to do, and scheduling electives, looking for places where you can make connections, going to conferences. It's so much of effort. It's possible, but I don't see it becoming easier. It's just becoming more difficult over time.
Oh my word! So we have to work hard. Okay.
Yeah, you have to work very, very hard.
So during an interview, what do you think are the do's and don'ts that we have to put into consideration when we are being interviewed?
The do's and don'ts. So the do's is definitely research your program extensively before you come in the interview. So you don't want to ask any questions to the program director or the resident that can be answered by looking at the program website. That's really bad look for you. So yeah, absolutely do your research. If sometimes you even know who, they will tell you in the email, this and this and these are the faculty that might interview you. You can look up on them. Some people will say they might list interest on the residency website, and if it's something you're interested in, you can prepare yourself to talk about that. But yeah, absolutely, researching is one of the big do's. Another do is don't forget to send thank you emails. So after after the program, after the interview, just shoot them a mail, say thank you for your time for interviewing me and for your insights on just mention one specific thing. Show you've paid attention. Don't make it long. They're busy people, but just message them and say thank you. If a chief resident spoke to you, email him to or her. If the program coordinator was there in the meeting, say thank you to him or her too. Those are two big do's. And don't people say be yourself, and it's funny, but like those conversations are very. The program directors want you to kind of be relaxed and just converse with them, and they just want to see, are you somebody that they can see themselves working with over time? You crack jokes with them, maybe you connect with them on one or two things. Yeah, it's not very obviously it's a high pressure environment because your career hinges on it, but the actual interviews themselves are usually very conversational. Some programs will pimp you and like give you a hard time. That does happen, but that's more rare. And then some don't. Mm, I don't know. Like, don't put anyone down. Don't, especially like if you're trying to say why you like their program, for instance. Like, don't disparage another program, uh, or another specialty. Like, you never do that. You don't talk bad about another specialty. Um, Yeah, other than that, I can't think of many don'ts. But there's abundant resources out there for when you're doing interview prep. The biggest thing is being prepared for what questions you might be asked. They might ask you if you're a cookie, what cookie would you be? Some very stupid questions like that just to see how you react in uh, an unexpected situation. There's no really wrong or right answer. Yeah, so just prepare for that. Then, will Canadians be required to get J1 or H1? Mm, I think the H1B is possible, like with everyone, but for the J1, you if you have Canadian citizenship, I don't think you'll be required to get the J1 visa because I don't know exactly how it works, but I've noticed that in certain cases, Canadian passports function very similar to visas given to other countries. So you just need to get documentation from the program and from ECFMG, and you still have to follow the same rules as everyone else if you're Canadian. But the actual visa and visa appointments, I don't think you will be requiring. As far as the interview is virtual, yeah, they've been virtual for the past 3 cycles, and all indications is that they'll continue to be virtual. That's a plus and minus for us because it's a plus because you don't have to travel and spend thousands of dollars interviewing, but it's a minus because people can hoard the interviews. In the past, if somebody had accepted 15 interviews, by the time you've traveled to like 5 or 6 different cities to visit 15 different hospitals, you're kind of done. And you know that your chances of matching is already almost 100% with 15 interviews. So you just stop. But these days, because it's virtual, I've seen somebody attend 23 interviews. I've seen one say he had 35 interviews. What somebody is doing with 35 interviews, I don't even know. But yeah, people can now accept as many interviews as they get. And these are going to be US students, not IM, because we don't get that many interviews. They will apply to like programs and get, 20 or 30 interview offers, maybe 15, maybe after applying to 40 programs. But for us, yeah, that's a problem. And that's why more spots are going to. So, where did I match? I matched at Chicago Med School. So, that's Rosalind Franklin University it's in the Chicago land area. So, it's like an hour up north of Chicago itself. So, I wanted to be in or around Chicago. I wanted a university program because I want to do cardio fellowship, and university programs help set you up more for fellowship than community programs. But also, if it's a really good community program, it will still have everything you need. So it's not like a hard and fast rule. But me, I just wanted a university program in or around Chicago. So that's why I got that's where I'm going. Yeah.
Another quick
I still have more questions.
Okay, let's go with John.
What kind of advice will you give a first-year medical student?
That would be that same thing I said when the session started, that as you study, just keep in mind that what you're studying for is not your next quiz, it's not the final exam, it's not the NDME, it's not step one or step two. It's for when you're a resident or you're an attending, and someone walks in the door, they're like, "Hey, go evaluate that person," and it's up to you to interview them, examine them, and come up with like an actually useful assessment and plan. Um, so if you keep that in mind, it makes it easier um, to do everything else. Like if you're studying with that mindset, prepping for quiz finals step is kind of like I don't say a breeze, but it's easier to do because those things just become obstacles you're crossing to get to where you're actually trying to go. A lot of people make the mistake of just focusing on that next quiz, focusing on the next final. Sometimes you have to do that in the short term, but uh, make up for it. Keep that long term in mind. You have to know the lab values for step. No, you don't, but it helps if you do. So by the time I took each of my step exams, I had memorized almost all the lab value sheets, and that's just because the seconds you spend pulling up the sheets, looking through them, you could spend thinking through other questions. So it's not required they will give you lab values, but the less you have to use them, the better your score will be for it. John?
I have another question. As a Canadian, like if we are going for rotation, I know you're saying it's better to do the USMLE exam before going for rotation. But most of us who want to practice in Canada, do we have to do the USMLE exam? Because we have our Canadian exam too before we go.
Okay, so that's different. Yeah, if me saying take step one is assuming that you're trying to come in and do residency in the US. If you're not trying to do that, absolutely, there is not much need to take step one. That being said, you will still have to know the information, right, so that you can do well. Because the Canadian match is even more competitive than the US match. I don't know if you know how the Canadian match works, but the US one is kind of open for everyone to come and compete, but the Canadian match has one round. Like the first round is only open to people who went to med school in Canada, and then whatever is remaining after that is what the IMGs will now compete over. So um, it is significantly more difficult to become a resident in Canada. Funnily enough, even if you're from Canada. For clinical rotations, is it best to do them in teaching hospitals or can we do private clinics? That's going to be up to your school. Obviously, the more hospital rotations you get, the better your training will be for it. But sometimes you have clinics, sometimes you have hospital with most schools. So, like my peds, family medicine, and OB-GYN were clinic. My internal medicine and psychiatry were hospitals. My surgery was like an in-between type of thing. So the training varies widely. It also depends on like how much your school cares about securing good rotations and everything. But no matter how good or bad the rotation is, what you know on the other side is completely up to you, and how much you put into studying. Um, yeah, funny. Like the good thing is that you have much more control over your knowledge and skills after rotations. And I think, how much did I pay? My school is the American University of Barbados, so their tuition structure would be there on the website. They not charge per rotation. It's I think 11,500 per semester, and there's 3 semesters, so not all 3 semesters per year. So something like 34, 500, 35 for 1 year of clinicals. Let's have John's question before we have any other questions.
Thanks, Paula. I think because I joined a bit late, so what would make of a good application?
Okay, so I'll refer to this program director surveys. So can get even more in-depth information if you just go on Google and type US Residency Program Director Surveys. You will see exactly what they care about from most to least. And so historically, the number one thing that program directors have cared about is step one. Obviously, that's gone now. Then after that, you have step two. That's probably going to move up into the number one spot. And then after step two, we have back your letters of recommendation, which, like I've been saying, you need to perform well in rotations to get strong LORs. There'll even be interviews where, like, you had a really strong LOR. They will bring it up in your interview and they'll be like, "Oh, this doctor really liked you." That never happened with me, but I'm like relatively confident that my LORs were strong anyway. So yeah, board scores, then LORs, and then after that they start caring about things like clerkship grades. Then they care about your research. I think research is actually above clerkship grades. So board scores, LORs, research. Then everything else is kind of like below that. Volunteering is important. Then clerkship grades, and that's when you now start seeing things like basic science grades, MSPE, which school you went to. But all those ones are always like very low on the list. Fortunately, the things they care about the most are the things that you have the most control over.
Thank you.
You're welcome. I see a question. I learned some rotations don't do much, just 4 hours a day. Yes, that is something. So you find out. I don't know where your school does rotations or how they structure them, but where I was, we would be in a hospital and there'd be 7 students on the team. The 7 of them are from 7 different schools in like 5 different countries, and so there are often more students available than, should I say, teaching slots. So what that does is that the ratio of students to preceptors is very high, and because of that, you don't come in every day on some rotations. Like when I was in my OB-GYN rotation, I got full credit for 6 weeks, but there were weeks when I would go in 2 days, weeks where I would go in 3 days. Like I said, the good thing with those rotations is that what you come out with on the other side is entirely dependent on you. So whether you work 12 hours a day or you work 4 hours a day for 2 days a week, it's completely up to you to determine how much competent you want to be on the other side. So like I was using Amboss for my study plans during clerkship. So I would track my progress. I would do my articles every day and my questions every day so that I completed the study plan by the end of the 4 weeks. And so if I had taken any self-assessment, I would have scored just as well as anyone who was working all day long in the OB-GYN. I'll say that where that's a disadvantage is if that's a specialty you're interested in. So like if, let's say I had been interested in OB-GYN, but now I have access only 2 days a week, and even that's not in a hospital, it's in a clinic somewhere. I never delivered a baby during my OB-GYN rotations, which I'm grateful for, but there's people who felt pain over that fact. So it depends on you. And then if that's your situation, then what you do is that after you finish your core rotation, you can then look for electives either through your school or on your own, where you would get the exposure you need for that specialty. Yeah, I had my internal medicine in a hospital, and so I did get a lot of exposure. I got too much exposure. But one of my friends that just matched the cycle, she had her whole IM in a clinic, and she was even messaging me like, "Oh, she's worried about looking stupid when residency starts." But I know her. I know that she has the skills she has to have to do well in internal medicine. So it will come down to you at the end of the day. It's like if you want to do surgery that you're in a surgery rotation where you don't get exposure, then yeah, that'll be a big bummer. But like I said, you can always try and look for spots either through your school or on your own to give you that exposure. I loved it. I hate OB-GYN, so going in 2 days a week was heaven for me. I have 3 of what I call hell no specialties, and yeah, OB-GYN was one of them. So going in 2 days a week, stay at home and read Amboss is like I couldn't have asked for better. once I start internal medicine, it's like, you have a baby, OB-GYN consult. Those mine is like the hyponatremia and the MI and the myocarditis and all that stuff. The baby stuff I don't want. Anything else? Sheila, are you good? Okay then. Yeah, so I think we can end it. I think we've answered all the questions. Like I said, if you guys have any more, just you can always email. Do virtual rotations count? It depends. So like if let's say you want to apply to family medicine, for instance, and you did a virtual rotation in OB-GYN as an elective, it wouldn't harm you in any way. But like let's say I don't know how virtual rotations are really structured right now. I know that during the height of the pandemic, you had these human cases you would solve on the computer, and a lot of students did have them. It's going to be up to your school to count those, like whether those count or not towards your final medical degree. Uh, if you have a virtual rotation, it's fine. If it's not the specialty you want, but if it is the specialty you want, you have to find a way to get some hands-on exposure at some point. Yeah, you're welcome. I actually fought my school hard over this virtual rotation because during the pandemic, everyone I knew, all their schools were doing virtual rotations, and my school stubbornly refused to do any. And so a lot of us got held back way more than we should have until we could go back in the hospitals and clinics. And I don't know, everyone who did virtual rotations, like they all match, they're all residents, they're all competent. So I don't know what good that insisting on the hands-on did for anyone, except if, like I said, you want that specialty. If you want to go into family medicine or general medicine, you have to know how to palpate to see if the liver is big. You can't learn that through a virtual rotation. So it's situational whether it counts or not. Anyone else? All right, I think we're good. So this has been a pleasure talking to you guys. Thank you so much. And yeah, I'll be rooting for all of you. Hope you all get the residencies you want eventually. Yeah.
Sure. Thanks, bro. Thanks, bro. Okay, bye.
Thank
Bye,
you.
everyone.
Bye, everyone. Bye.